think we're going to start. So just let me, everybody, welcome. I see that more people is joining. We have today Dr. Esteban Foianini. He's a surgeon and medical director of the Foianini Clinic in Santa Cruz, Bolivia. He's also the past president of the Panamericana Trauma Society and past governor of the American College of Surgeons. Welcome. We know you are very busy, and also this is a very important topic for Latin America. So we're very glad to have you here in that short notice. And I will let you introduce yourself, please, Dr. Foianini.
Very good. Thank you so much for the kind invitation. And for me, it's a real pleasure and honor to be able to share some time with all of you. And I hope this leads to some further discussion and hopefully some partnership with Pan-American Trauma Society. I'm still a member of the executive committee. We just changed our executive director. It was Tom Scalea, and now it's Antonio Martos, who's a Brazilian surgeon, works at University of Miami, and the current president is Paula Ferrada, who is a trauma surgeon in Virginia, but she's originally from Cali, Colombia, and her father is well known in Colombia, Ricardo Ferrada, as a trauma surgeon in Banaco, and also at another hospital in Cali, not a fundación. But happy to be able to join you guys.
Thank you so much. Just a last reminder, I see more people is joining. So if any of you need translation into Spanish, Jody is welcome to do that. So please let me know by using the chat in case you need translation. Well, I'm going to just let you share your screen so we can start the conference.
Vamos a comentar en español, los que acaban de conectar. ¿Necesita alguien interpretación al castellano? Si es así, podemos hacerlo, pero si no, iríamos directamente en inglés. Pero si necesitan, podemos activar la interpretación.
Sí. Muy bien, voy a hablar. I'm going to speak about the necessity to develop trauma systems in Latin America. This is my personal view. And this, I will also talk a little bit about the role of the Pan-American Trauma Society, which is based out of Virginia, and how I think they should play into trauma system development within our region. So when we discuss trauma systems, it's important to talk about the definition. So it's an organized, coordinated effort in a geographic area that delivers a full range of care to all injured patients, and is integrated with a local public health system. The true value of a trauma system is derived from a seamless transition between each phase of care, integrating a system resources to achieve improved patient outcomes. And I want to be clear that as far as I know, there's no real trauma system that exists south of the border, as it would from Mexico all the way down to Tierra del Fuego. So this is a combined collaboration of injured patients, and it emphasizes prevention and returning the patient quickly back to society. It's a coordinated care and comprehensive, defined within a geographical area, and the coordination is effective and cost efficient, and these are characteristics of a trauma system. It needs to include preparations for disasters and also simulation. We have to make sure that the people are properly trained and have the necessary resources at their disposal to care for the injured patients. So when we look at the components of the trauma system, there are different definitions, but most of them talk about 4 components. You have the pre-hospital component, the acute care facility or trauma center, and then you have to discuss rehabilitation and the return of the victim back into society. And the 4th component for me would be education and prevention, which I think is crucial in this discussion. So when we talk about trauma deaths, and probably a lot of you guys have seen this image beforehand, it's estimated about 5 million people die due to injuries every year, which is 1.7 times the amount of people who die from HIV, TB, and malaria. The difference is that more funding is implied within these disease processes than is advocated for the care of the injured patient. And This represents a total of 9% of all deaths worldwide. Now, I don't want to belittle the COVID pandemic. I'm not an anti-vaxxer. I was very much involved with caring for COVID patients, but the reality is the world closed down in 2020. And when we look at the reported deaths, there were 1.8 million deaths that were reported, but it's estimated about 3 million people died that year due to COVID. And the world reacted. And we're looking at 5 million people die every single year related to injury. And we kind of take it as matter of factly. People fall, people commit suicide, people have motor vehicle accidents, people are shot. And we just kind of become immune to this and realize that the world took a strong stance when we're facing 3 million unexpected deaths. And I would argue that the vast majority of the injured or the trauma deaths are preventable. The reality is in Latin America is a little bit different. Trauma deaths, we said worldwide it's 9%, but in Latin America it's about 11 to 13% is due to trauma. And the disheartening part of this is that people who are injured in low to middle income countries have twice the mortality of people who die in high income countries. Based on information from the World Health, the mortality that's caused by vehicular accidents per 100,000 people is 6 per 100,000 in the European Union, 12 per 100,000 in North America. Mostly that's reflecting the United States as the Canadian numbers are lower. But in Latin America, it's 16 out of 100,000. But in sub-Saharan Africa, it's 27 per 100,000. And when we look at trauma deaths, 90% of them occur in low to middle income countries. And 80% of these deaths occur in the pre-hospital environment. So the vast majority of people who die within the low to middle income countries never arrive to a hospital facility. Looking at the spread across Latin America, Argentina has the lowest number at 5.7, but Venezuela, and these are related to trauma, Venezuela has almost 20% of the population die related to trauma. I'm not talking about motor vehicles, this is a combination, and many of these are from violent injuries. Colombia is the second highest in the region with 14%, but Bolivia is fairly high, 8.7%. And this is just gonna get worse. This is a compilation from the World Health, it's an estimate, and looking at road traffic injuries back in 2012, it's estimated that there were 9th cause of death worldwide, and that's gonna rise up to 7th by 2030. Suicide rates are gonna stay about the same, and the number of people who die from falls, and this is related to the elderly, and as the population worldwide is getting older, we're gonna be facing more people suffering from traumatic injury secondary to falls, and this is usually in the elderly population. This is an old slide from 2014, but when you start looking, everything that's marked in black here, this is worldwide, death related to trauma, and you can see that in the groups from 5, I can't see the exact dates there because of the bar, but up to, I believe, 39, it's road traffic injuries. But you can see a nice spread between 5 and 44, which is usually what ATLS teaches you, that this trauma is a leading cause of death in those age groups. Now, when we start looking at the reality in Latin America, and unfortunately there's not good data, this goes back to 2008, but it's data from 2004, you start seeing everything that's circled in red is related to trauma. And this goes from motor vehicle accidents, drowning, interpersonal violence, and suicide. And it goes through all stages of life. So I was just stating beforehand, after the age of 70, falls is the leading cause of trauma-related death in that population. But you're looking at people between 5 and 44, the most productive group in the sense that they're young students, they're head of households, responsible for kids when they get into the 20s, 30s, and 40s. And these people are the ones who are suffering most from trauma-related injury. When we start looking at distribution of death, it's about 13% in Latin America, as I mentioned beforehand. And the one thing I'm not going to get into much details is how that affects dailies or disability adjusted life years, it's 18% worldwide. And this is kind of a distribution of the mortality cost per 100,000. This is a map. You can see that mostly Africa is affected here, but Southeast Asia and Latin America as a continent comes in third in relationship to poor outcomes. And you can see there's a wide distribution. Canada within the Americas has the lowest number. There are no numbers for Venezuela because they're not appropriately reported, but Dominican Republic surprisingly has the highest incidence of this report from 2016, but Bolivia and Brazil are fairly high up there too. And what's even more concerning is if you look at the data, rich countries, and here they're related to some European countries, United States and Canada, over the last 20 years or 30 years, there's been a marked decrease in the deaths related to motor vehicle accidents. But the reality in developing countries is that places like Cambodia or India, those numbers are going up. And they're going up because more people have the capability to purchase motor vehicles, and there's more traffic on the road, there's more chaos, and there's a lack of infrastructure and lack of trauma system development to provide care for these patients. When you look at deaths related to injury, the mortality is higher, again, between lower and lower middle versus upper middle or high income countries. So there is a clear disparity worldwide in this respect. So why do we have a proportionally higher incidence of deaths related to trauma in Latin America? And I believe it's because we have a younger population. Life expectancy in Latin America is less than most developed countries. Violence is more because the reality is that we have to deal with guerrillas. There's the famous drug wars, there's poverty, there's social inequities. The conditions of the roads are very poor. Nobody follows any traffic rules. There are no pre-hospital systems. And if they exist, they have many deficiencies associated with them. And the majority of the urban cities in Latin America do not have a formal trauma hospital, and they definitely don't have an implemented trauma system. And one thing I've had to experience from a personal standpoint is the fact that there are very few rehab centers that are available throughout Latin America, and these can be either very costly or they're just not available to the vast majority of the population, which further compounds the issues that we have to face. So this is an image I took when I went to Haiti during the earthquake in 2010, but this could be anywhere in Latin America. I've seen something like this in Bolivia, and clearly there is no sense of people being safe on the road. Other reasons that mortality is increased is because, like I said, there is no real trauma system. And in many countries, there is not even a formal training in trauma surgery. Courses like ATLS, PHTLS, ATCN, and I'm an instructor in these courses. They're excellent courses. We've been teaching them in Bolivia since 1998, but they are expensive. A lot of physicians can't afford it, and they're not accessible to many professionals throughout Latin America. And also, natural disasters have a major impact because there is no planification, and we do not meet with building codes or basic services in a lot of areas that are at risk. This highlights, again, my experience in Haiti. This is a construction right next to the hotel we were staying at. And you can see the construction, the bricks are just being laid up with no real sense of structure or integrity. And the consequences is this. So I think a lot of this was the reason there was such a high mortality in that earthquake in that country. And when we start looking at deficits of surgeons worldwide, we go back to Africa is the continent that's hit the hardest, but again, places, even India, that has a very strong medical population, very recognized, they do have strong deficiency, but most of Asia, and there's deficiencies throughout Latin America. The reality is 5 billion people worldwide don't have access to surgical care. And when you start looking at the numbers, it's really daunting that 94% of the population in low to middle income countries do not have access to surgical care and secure anesthetic care. And that's compared to 15% in countries with high levels of income. Only 3.5% of all surgical procedures happen in the poorest countries, where a third of the population live. And the reality is that trauma requires dedicated trauma surgeons who are highly qualified. And I'm not going to get into this, and Dr. Moser can expand on it later on, but there's a definite need for qualified neurosurgeons across the world, and definitely again in Africa. And one of the things I didn't highlight there on that slide. Bueno, one of the things. Si pueden apagar el micrófono, por favor. So one of the things I didn't highlight there is that it's not only the lack of availability of surgeons or surgical capabilities, but it's when the population has to go and receive surgical care, this creates a tremendous economic burden on these individuals, which then financially hinders their ability to take care of their family. When we start looking at the millions of people who die every year due to violence or injuries, this is a fraction of all those patients who are eventually injured. And we are not taking into account the number of people who suffer discapacities or dailies. This is an injury pyramid, which you're probably familiar with. And we're just seeing the tip of the iceberg, as I would say. It's fatal injuries, and then the number of people who get hospitalized. And even in Bolivia, a lot of people never even make it to a community hospital and get just treated locally or do not receive any treatment within any part of the healthcare system. So when we start looking at trauma systems, we have to question ourselves if these are effective. And since 1984, there's more than 15 articles that have been published demonstrating a benefit in survival through a trauma system. There's a study back in 1979, which compared Orange County in California, which did not at that time have any designated trauma center, in San Francisco, which was one of the largest trauma centers in the United States. And they encountered that in Orange County, the number of preventable deaths was 37%, and in San Francisco, it was 6%. Another study, which was published in the New England Journal of Medicine in 2006, comparing trauma centers, 18 trauma centers and 51 hospitals without trauma centers. But these are large hospitals that did have, some of them had designated trauma directors, and they demonstrated that the mortality outside of a trauma center was 9.5% versus 7.5% within the trauma system. And what they were able to see is that the difference is mostly amongst younger patients with a higher ISS score. This is a systematic review of the literature that's looking at 19 studies, articles that were published in English and German, and it covers kind of the gamut. Some studies coming from the United States, some of them from Europe, from Ghana and Africa and Iran, but the majority were concentrated in high-income countries. And what they encountered is that the pre-hospital mortality oscillated between 14.5% to 47%. And looking at one of the studies from the United States, which had the lowest preventable mortality rate, was 4.5%, but the one from Ghana was almost 60%. And it's estimated between 5 and 10% of deaths related to trauma globally are preventable, and a much higher are potentially preventable, between 25 and almost 45%. And the most common causes were because there was a delay in treatment. We're talking about traumatic brain injuries, airway management, providing oxygen, and there were also errors in the management, and this accounted for about 30 to 80% of these errors, and they consisted of not providing adequate fluid resuscitation, not providing blood, and not controlling the airway. This is an interesting study that comes out from Seattle, from Charlie Mock, and he looked at mortality within 3 systems. Seattle, Washington, which has a very robust system, Monterrey, Mexico, which for Latin America, I would presume has a very good system, and then finally getting back to Ghana. And based on an ISS greater than 9, the mortality in Seattle was 35%, Monterrey it's 55%, and in Ghana it's 63%. And he estimated that annually about 1.7 to almost 2 million lives could be saved if everybody had a robust trauma system. Now, that is not realistic due to economic constraints and education and facilities and government commitment. But he presumes that there could be a significant diminution in the mortality associated with trauma worldwide if some changes would be instituted. So what are required within the trauma system? We talked about the pre-hospital components. So we have to have an integrated call system. We have to categorize and coordinate the ambulance. We have to have agreements amongst hospitals, and we have to have referrals and counter referrals. Hospitals need to know what are different capabilities of each institution and which institution can handle which type of patient. Just kind of a side note, one of the ER doctors who's also a surgeon was telling me that he got a stab wound in his emergency room. And since he was a surgeon on call, this is not at our facility, this is an outlying public hospital. He took the patient for a laparotomy. It was a knife wound to the abdomen. And the patient was a young patient with stab wound to the aorta. For most well-trained general surgeons, that's a fairly straightforward case. And the reality is that due to his training, he didn't have any vascular experience. He really didn't know what to do. And the patient died on the table. And that's reality. The patient should never have arrived to his hospital, should have been deferred to another institution. He should have known earlier where to transfer the patient if the patient arrived. But none of those things have been worked out, at least in Bolivia, and I suspect in many regions throughout Latin America from conversations I've had. There's a lack of training for paramedics and medics. The reality in Bolivia is that there are no paramedics, and the physicians who are part of our pre-hospital system are people who graduated medical school, but who have not been able to enter into a residency program. So it's a way of getting a job. And they don't even do the basic PHTLS or ATLS courses prior to starting their involvement. The second phase would be acute care. Here we need surgeons, intensivists, and other physicians who are part of the components of taking care of a trauma victim. We need specialized nursings. We need high quality imaging, CT, MRI, angiography has come into play a major role in trauma care. But the reality is most institutions do not or cannot offer these technologies. And I can state, matter of factly, that we're the only institution that I'm aware of that is using angiography to treat trauma patients. After the discharge, we talk about rehab centers, and there's truly a lack throughout in Latin America of rehab centers. And finally, education. In a lot of places, it's non-existent. There are some very good programs. In Brazil, they have Mayo Amarillo, which is started by the people at Campinas. I believe Gustavo Fraga, at least he's running it right now. And it's awareness of the population as far as how to do trauma prevention. Also, the need to develop trauma registries and performance improvement programs. This is an image from Santa Cruz. I actually asked the call center at the hospital where I work, please provide me the list of ambulance services. This is ungodly. This is ridiculous. And it is a common theme. There's an article also by Charlie Mock that talks about issues with trauma systems worldwide. And one of the things he highlights is a lack of a uniform number to be able to call. So what people end up doing is they just get into their personal own vehicle, or they just call a local hospital and ask them to send an ambulance, because there's no way you can recognize or remember all these numbers. So what are some of the solutions? We need to provide more courses to train surgeons, physicians, residents, nurses, and paramedics. Educating people in developed countries doesn't really work. it's very rare that a physician will leave a low to middle income country, train in a high income country, and then return to work there. There was a whole graduating class in Cochabamba, Bolivia back in the 1970s that got jobs in Chicago. And I believe there were 100 graduates. Not a single one of them returned to Bolivia. And that's just the reality. So that is very difficult. So the sense that you're going to go train in the United States or in Europe and return is not the usual way these things work out. There are clear exceptions. On one of them, I trained in the United States, but it's not common. So my feeling is that physicians, surgeons, paramedics, and nurses who are highly capable should go out and get involved with global surgery and visit these countries and look at the local problems and help develop the trauma systems in those places. There's a clear role for rotations, for observerships, and formal training. One of the things you have to work on is you have to work on the local legislation to start changing it so that you can provide resources for the development of these trauma systems. And the trauma registries helps to show the evidence of where the problem lies and how you need to start changing your system and what are the requirements to be able to provide for prevention and for the treatment of these patients and eventually recovery. And finally, hospitals within the region need to start developing performance improvement programs. Again, I think we're the only institution that I know of in Bolivia that does routine M&Ms. And I've even visited some very large institutions in other countries within South America, and they don't run, for the most part, M&Ms and don't do any PIPs. So when you start looking at trauma systems, you need to identify the stakeholders. You have to involve the public, the private sectors, the politicians, start changes legislation. We started working in Bolivia about 10 years ago, and all of our work got truncated because of COVID. But one of the first things was to go talk to the governor of Santa Cruz, talk to the Secretary of Health, and we had fellows who were coming from the United States who started working and they started modifying legislation. We started working on coordinating the system, developed the Cruz, and started to get that whole host of different numbers where there was a single number that was supposed to work and was able to coordinate the ambulances. If there is no coordination amongst the different services, which is where we unfortunately fell back into in Santa Cruz after COVID and the change of the local government, the local ambulances come into direct competition amongst themselves. And because there's a financial reward, especially if it's taken to a private institution, and the ambulance will come into direct competition to really affect the quality care that's provided to the individual who was injured, unfortunately. We need to start doing corrective actions, which are directed, like I stated, training people who are providing the care at all levels. And one of the errors is to try to implement what works in places like United States, Germany, Italy, France, into low to middle income countries. We're all different. We all have different challenges. And what needs to happen, and based on this article and also my personal experience, is people with experience need to come and need to look at what's going on the ground and what are the real needs in each place, and then coordinate with the people who are committed locally to develop these systems. So how does the Pan-American come into play? The Pan-American Trauma Society is a society that was founded by surgeons from North, Central, and South America. Actually originated in Mexico, but its offices are at Virginia Commonwealth University in Richmond, Virginia. And they have several courses. These courses have been developed in the vast majority by Latin American surgeons, and they tend to address the issues that are local to our region, and the price structure is much lower. We've had some issues with updating some of these courses but after COVID, there's been a big push from the society, and almost all these courses are brand new as of the last, or been updated, I should state, over the last 2 years. There's also the whole sense of implementation of a trauma registry, and I'll discuss that a little bit more, and also possibilities of observership, not only at VCU, but also at Miami, the University of Maryland, and other institutions in the United States affiliated with the Panamericana, and also in Colombia, in Brazil, and Qatar, and Abu Dhabi, if I'm not mistaken. So why is the trauma registry important? This provides us information which shows evidence to make the system more efficient and improve the quality of care. Once you analyze the information, you can start creating improvements within your system so you can help you make decisions and evaluate how you're performing and start benchmarking against other institutions. It's a fundamental part of the performance improvement programs. And there are several registries that exist worldwide. One of them is the one from the Pan-American Trauma Society. It was run out of Richmond. It had 3 levels, and the first one is open, is completely free. Mike Abutanos from Richmond started this, but the information has been transferred to Cali, Colombia, and it's run by Dr. Luis Fernando Pino there. Another one, which is a very good system, Fundación Trauma. It's run in Argentina by Jorge Neira, who's an intensivist. There's a fee associated with it, but they've done great work in Argentina, and they start expanding in other countries, and I can provide you with information. The World Health Organization has been working on a trauma registry, an emergency care registry, which is free. It's based in certain measure on the Pan-American Trauma Society registry, but they've been modifying it, and it's well integrated, and that's another phenomenal tool. And then one of the other ones I worked with closely is from McGill University, Dr. Tarek Razik. He has a free registry, which he's implemented in Africa and is available from people, and I can provide the information or the contact for that too. So as far as the Pan-American, one of the things I proposed in my presidential address is that we start from grassroots. We've divided our spheres in 3 groups. So we have North America group, we have the Latin America group, and Brazil as a separate component. But one of the individuals who's a director from North America, Dr. Mark de Moya, the idea is that he will work closely with different surgical societies, the COT, the AAST, East, and Western, and also with different academic centers. And kind of my personal experience in the past, there is a big push for global surgery, and I think it is a benefit for trainees to come from the United States to Latin America and work mostly in trauma system development and get assistance from their professors from the United States. At the same time, also organize for observerships or sending individuals from Latin America back to North America, or as I mentioned, to the Middle Eastern countries where we have connections, and allow them to also gain certain knowledge and insight. There was a recent fellow who went to Boston to Brigham, if I'm not mistaken, and he was a research fellow, just learning how to write papers, and therefore come back to Colombia and help the group in Cali with publications and be able to present all of the data. And finally, the group in Brazil also working kind of the same concept. And these things was how we started developing the trauma system within Santa Cruz. And things worked wonderfully until COVID hit us. That was kind of stopped us. And like I mentioned, unfortunately, and it's a reality in low to middle income countries when there's a change of the structure of the government, everything that was done before just gets erased and they want to start all over again. And unfortunately, we have not had much assistance from the current governor's office in Santa Cruz. So the reality is that trauma remains a surgical disease from cradle to grave. But having stated that, I don't think that trauma is just meant for the surgeons. I think that, like many things, it's a team sport, and we need to include I could not do my job if I didn't have quality neurosurgeons, quality interventional radiologists, quality imaging individuals, great nurses, people who assist me, ER physicians, the pre-hospital component that comes into play, quality improvement in the hospital. Everybody in the hospital has to come around and work, and everybody has to be involved and appropriately trained for this to work. So in summary, trauma is a major cause of death between 5 and 44 years of life. The majority of deaths occur in low to middle income countries. We have to consider the impact of dailies. It does affect the poorest countries and disproportionately at the poorest people within those countries. We need to create trauma registries to understand the magnitude of the problem and create performance improvement programs. We have to create trauma systems to prevent and improve the care of the injured patients. And I believe that PTS can be a part of this, but we also have to work with the local societies, with international societies, and with some NGOs with this. So how do we accomplish this? And this is a nice little tale. Have you heard of tiny Melinda May, who ate a monstrous whale? She thought she could. She said she would. So she started in right at the tail. And everyone said, "You're much too small." But that did not bother Melinda at all. She took little bites and she chewed very slow, just like a good girl should. And in 89 years, she ate that whale because she said she would. And I think that's how we get to this. This is not going to change in my professional lifetime. I don't think. I wish it would. But it's going to take commitment. It's going to take baby steps. It's going to take probably decades to accomplish, but we need to start somewhere with all of this. And as they say in The Mandalorian, this is the way. This is where I started learning about trauma. I did work at LA County for a period of time as a surgical resident, but really it was my time in the US military in Kosovo. And any questions, please feel free to contact me via email. And also, if you're interested in the Panamericana, that's our webpage right there. We have a meeting this upcoming year in Lima, Peru. We're going to have people from North America, Central, South America, Middle East, Europe coming in as speakers. It's a multilingual, multi-specialty conference. We have paramedics, we have surgeons, intensivists, ER physicians, nurses, the whole gamut. So thank you, and thanks for the privilege of being able to speak to you today.
Thank you so much, Dr. Foianini. It's an honor to hear about you. Of course, we have, the Latin American Working Group, but for sure, all the G4 Alliance members are here to support, all the work that it needs to be done in our countries related to trauma. And of course, we're going to share, the information about the conference next year, and you are always welcome to join our working group every month of the year. I just opened the mic for everybody who has questions. We have about 15 minutes.
I just want to say thank you very much. It was a delightful talk. It's odd that here I am in Cape Town and it's almost 1 o'clock in the morning. But what am I doing here? I'm talking about the very thing you highlighted, which is the need, in this case, neurotrauma, the World Congress for the World Federation of Neurosurgical Societies is meeting here. But they wanted me to talk about what we're doing in Bolivia, which is really all about how it is a team sport. That's what we're initiating in Sucre, this idea that we have to incorporate emergency medicine, anesthesia, neurosurgery, neurocritical care, and rehabilitation. And we have some really good ideas about rehabilitation as well that you might be interested in. But the idea that we have to go from pre-admission resuscitation to post-discharge rehabilitation if we're really going to be able to move the needle and improve outcomes. So fantastic. And thank you for presenting.
Thank you, Richard. Thanks for inviting me.
Ruben?
Thank you for a fantastic presentation, Dr. Foianini. It's a pleasure to hear you, to hear your insight, your experience, and your outlook for what we need to do forward. The mention of how governments seem to erase the previous progress and start all over again does not escape me, and I'm sure it doesn't escape the rest of our friends in this call. Is there a way for us to make a case that if you invest in maternal, which the world global health is investing so much on, and in trauma systems, maybe we're 70% of the way in getting to 100% and covering the infrastructure systems that might be required for good surgery to happen throughout? That would be the question. I mean, do you consider that if we were to do trauma, we'll be in a good place, advancing a good portion of the 100% that we will need to take care of people with surgery and anesthesia? And then the second one was, would it be possible for us to at some point have a discussion with you about how we can, as an alliance, maybe work on an event that brings that advocacy, the advocacy efforts that we're undertaking, and joins with you and others in this upcoming meeting in Peru? I think the trauma world is so well prepared, and yet we haven't really engaged with as many of you who are so outspoken and well poised to guide some of the messages. So I'm sorry, it's a bit of a common invitation and also a question.
So it's perfect. So the reality is politics at all levels in Latin America is difficult. So even when I've dealt with surgical societies, we obviously not going to mention the country, but we came to an agreement with the president of a surgical society. And I'm not talking about a small country in Latin America. It's a very big, well-established country. And after getting down, we did not sign the agreements because it said, oh, you'll do that under the next president of the surgical society. And we had to start all over again. And that is a failure, and this is a cultural thing. And we face the same thing in the government, because you might think that the change in government is that we went from a leftist to a centrist, or centrist to a right government. These are all central right governments. I'm talking about the state governments in Santa Cruz. They are opposition to MAS, to the leftist, if you will. Doesn't matter. They all hate each other, and they don't want to have anything to do with the predecessors, because they don't want to be looking like they're growing on other people's shoulders. It's a very cultural thing. So I think, and I don't want to take away from your desire to work with governments and politicians. I think we have to. I don't like to. We have to. We have a little bit of different sense, and I will mention one more thing in relation to that. But I think that from a personal standpoint, from the private sector, from the individual standpoint, we need to do this because it's important. It's important. It's probably not going to make a difference in my life, but it's going to make a difference in my family, in my community, in the structure. And it's the right thing. It's what needs to happen. And I had the discussion with the Secretary of Health at that time, and when I presented to him that developing a trauma system and getting numbers would decrease trauma deaths and we provide better care, he wasn't interested until I told him he was going to save money. And that's how you get to politicians. They're all about the money. And it's unfortunate, but it's the way it is. So your second point with regards to working together, absolutely. I'm still a member of the executive committee of the Panamericana. I'm invited to be part of the program committee, and actually it's occurring right now. So they're discussing what things are going to occur. But I will take you to that stance. I think it would be great to work with G4. I will text Dr. Tolino, who's a Venezuelan surgeon who works in Chile right now. He's in charge of that, and highlight the fact that we need to get you guys involved. I would like to get people from the World Health Organization down to Lima and sit down and find how we can work together, because we all have a common goal. And I'm at this stage in my life where it's not if you are American College of Surgeons, if you're Pan American, if you're Bolivian, Chilean, Colombian, Venezuelan, you know, we're all the same. We all have common goals. We all want what's best for our patients, for our families. So let's work together and let's be collaborative. And ultimately, whoever takes, you know, the reward doesn't really matter as long as things happen. So let's find a way to work together, assist each other, and move forward.
Thanks,
So yeah.
thanks.
Yeah.
Very refreshing. Thank you so much. Look forward to that.
Thank you so much. Jody?
Yes, thank you. This was absolutely fabulous. And of course, I completely, I agree with you and I commend you for realizing, I mean, it's a team sport and we need change from the highest levels. You need to change the legislation. My question is, and I think you're the one who, I'm so glad that you are passionate about this in Bolivia, because I think, you know, if anybody can achieve this, I think you and your team can. In the meantime, just today, I got an email from some general surgeons in Cochabamba, not from them, but from communicating that they're interested in, they work in the Vietma hospital, the third tier public hospital in Cochabamba. They cover the ER. They're general surgeons, fantastic surgeons, very experienced. They get the trauma cases, you know, at this public hospital. They have to deal with them, and they weren't trained in trauma surgeons. They're general surgeons. And they've mentioned, like, you know, we'd love some more training. You know, we deal with these trauma cases. And, you know, is there any role for, you know, an international organization like Solidarity Bridge? I mean, trauma, it's not like you can save the cases, you know, for when a team comes and let's, you know, do a mission trip. It's not how can we help surgeons who don't have this training, but who are, you know, who have to manage this before we change the legislation?
Correct. So unfortunately, surgeons believe that they can take care of trauma because it's just a hole in the bowel. The liver got banged up, you know, guy got hit on the head. How difficult is it to put a chest tube? And they have kind of this mindset because they haven't gone through the training. I would say that from a technical standpoint, there are some things that are technically different when you're dealing with trauma patients, but it's a mindset. You have to think differently as a trauma surgeon. When you're dealing with acute trauma patient, you have to think differently. And unfortunately, these individuals are not trained in that respect. And that's why I highlight courses like ATLS were never meant to make you a trauma surgeon. What ATLS teaches you, and I've been teaching it since 1993, very long time. It's meant to deal with the first hour of injury in the patient and how to prevent further injury to the patient. But there are other courses. Unfortunately, courses like ASSET, it's a great course, very expensive, very difficult to do. It's never been done in Latin America because you need fresh cadavers. There's ATOM course, which is also from the American College of Surgeons. Again, very expensive course. It's about $2,000. They've taught it in Brazil, in Colombia, and Paraguay. So I don't think that's feasible. One thing that we're working on right now is revamping the Destrezas Quirúrgicas en Trauma, or surgical skill course in trauma. That's a Pan-American course. It was originally taught by individuals like Raul Vaturi, Aurelio Rodriguez, Kim Mall, Tom Scalia, big name surgeons. Unfortunately, never had a text associated with it. That is changing now. Pablo Tolino has taken charge of it. I'm part of that work group. He's translating, he's developing videos for the course. Videos will be in English and in Spanish. And he's already taught it remotely from Latin America last year in Spain. So it can potentially be a video-based surgical skill course, which presents, and he'll have live videos showing you the injuries and how he handles them. And there was also a possibility of this being an in-person course. We did teach this course in its original version in Bolivia several years ago, but we had to have large pigs for this, and it was during one of the Pan-American Trauma Society meetings. But that's something that we've discussed, and I think it is a prime necessity. We have to find how we do it inexpensive, and then expensive part would be without the animal model. And then for a few surgeons who are interested, do the animal models in case they want to get some skills. But I go back to the whole sense, they need to understand the principles. And I can spend hours discussing things I've seen here where they have not followed common trauma principles, and therefore the patients have ended up injured. Okay. The whole concept of non-operative management, the whole concept of interventional radiology and angiography in these patients, and doing and preventing harm, you know, what Richard does, you know, preventing secondary brain injury. All these things need to be discussed, and that can be done in one of these settings. So that's something that the Pan-American is working on. The college, unfortunately, has gone very much to the surgical technique route, not the discussion part, although they do have some part. And like I stated before, the college products are great, but they're expensive. So the Pan-American is trying to work around that. And I don't want to disparage, because I work with the college, but it's just a different mindset. So that's what we would offer here in Bolivia and the rest of the region in the near future. I should also state that there is a DSTC course, which is run by the European Trauma Society. And if you want, I can contact Gustavo Fraga, who's the responsible person for Latin America for that course. Because again, it's not about the society, it's about getting the information out to people, and then people making a decision, what works best for them.
Thank you,
So
Dr.
Carolina,
Foianini.
I think this should be a major initiative of our group and of G4 Alliance. So just,
Yes,
I'm
totally.
endorsing the idea.
No, totally agree. That's what I was thinking. I was about to say, Dr. Foianini, that I will send you the invitation to our working group meeting. So in which we discuss opportunities and plans and, you know, networking and how to move forward within the G4 Alliance and beyond within the region. And also we share with you the projects that each of our organizations are working and how, so then you can see how it will fit with your goals. Well, I think it's already 6 p.m. here. If we don't have more comments or questions for Dr. Foianini, I think we keep working in, you know, further in how to collaborate in the next meeting.
Yeah, I just want to thank again, Dr. Foianini. This has been really, really so valuable. And I do hope you can share all those resources. I was taking notes, but fortunately we have this recorded. I'll have to go back. That's what we need to connect with all these resources and share them with people. You know what the need is here. You understand how important this is. So thank you. And definitely if you could join one of our, it's always the third Wednesday of the month. We have working meetings where it's more, we talk about projects and what we're going to do together. It'd be really helpful if we could coordinate it, that you could participate.
Yeah, it'd be my pleasure. Wednesdays are a little bit difficult for me, but depending on the time, we could probably make it happen. And I saw one of the comments Dr. Uribe mentioned, Juan Carlos Salamea. He's the current secretary of the Pan-American Trauma Society. He's very much involved in training, and they have a fellowship in Cuenca. So, but he's part of the whole work group. So Dr. Uribe, just so that you know that he's very much involved with us in all these things.
Thank you, Dr. Foianini. And yes, if not any Wednesday, we can set up a meeting, just, you know, a separate meeting to explore opportunities. And also I would like to let you know the work that we're doing with PAHO, because as you know, they work, you know, in relationship with the country's needs, and, you know, they manage government budgets. But we can do that the next meetings. Thank you very much for your presentation, for all the participants, and we will share with everybody the recorder so you can expand, you know, this presentation beyond us.
Gracias también, Esteban, por la presentación increíble. Gracias por representar Bolivia también. Y como siempre, la Clínica Foianini ha sido un apoyo para Operación Sonrisa en Bolivia desde hace años atrás. y agradezco que hayas estado y hayas dado una presentación increíble. Muchas gracias.
Muchas gracias, gracias por tu palabra y para mí ha sido un verdadero gusto compartir con todos ustedes. Y esperemos que hagamos cosas interesantes y que esto lleve a una buena colaboración. Como dice una de mis películas favoritas, Casablanca. This is the beginning of a wonderful friendship.
Es verdad. Muchísimas gracias
Sí.
para todos y nos vemos en la
Ok.
próxima reunión del grupo. Hasta luego.
Gracias.
Que estén
Buenas
bien.
noches.
Gracias. Buenas
Buenas
noches.
Buenas noches, hasta luego.
Buenas noches, gracias.
Hasta luego.
Thank you.